Warmly welcome, everybody. I will talk briefly about my research and about this ET solution that I and my research group have developed. First of all, this is a short information on what is this person who's standing here. Who is she? I'm a registered nurse anesthetist, and I nowadays work in the postoperative care unit here in Huddinge, bedside with the patients. And that I'm also a professor in nursing, so this is a combination of being in the clinic and in the Karolinska Institutet. At Karolinska Institutet, I'm a professor, as I said. I'm also a teacher, and I'm doing research, and that is what I'm going to talk about now, my research. My research area is perioperative care, and it's about to test and develop interventions that can increase quality of care, of recovery, and it can also to increase patient safety and support the patient. And I'm doing, mostly it's clinical trials, but I also do some psychometric testing as well. So what is the perioperative period? The perioperative period can be divided into three phases. First, the postoperative period, in which the patient, it starts when the patient gets cancelled, should go to, it's admitted to surgery. And it could take a long time or a short time. If it's emergency surgery, this period is very short. Then it's the intraoperative period, when the patient is under surgery. And this period ends when the patient is admitted to the postoperative care unit. And at the postoperative care unit, you can see first it's the early period. And then it's the intermediate period. And these two periods are at the hospital. Thereafter, the patient is discharged, and he and she is going home. And then the late and the long-term period, postoperative period, starts. In Sweden, we perform a lot of surgeries, almost around 2.5 surgeries, and most of them is performed as day surgery. And you can see around 70 to 75% is performed as day surgeries. And my research area is those patients that I'm studying. It's day surgery patients, and you can see it's almost 2 million procedures a year that is performed as day surgeries. And what is the patient's view of day surgeries? The patient thinks that it's excellent care in the hospital. However, when the patient is coming home after discharge from the hospital, they have very little knowledge about how the recovery is and what is normal, and they feel very lonely, and they do not know where to turn to when they are coming home. And so this is a very important issue for me to discover and to find tools to help the patients. It's also important that if you are going to measure how the patient experience their recovery process, you have to have validated metrics. You can't just ask the patient. It could be good to just discuss with the patient, but if you must do this also systematically, so that you have evidence to do intervention and support the patient in their care. So for me it started with a contact with Professor Paul Miles, who is an anesthesiologist in Australia. He had developed a questionnaire called Quality of Recovery 40. He, as me, worked in the with anesthesia, and we wonder why we didn't check up how our patients, what they experienced, how they feel after having anesthesia. You mainly often check up the surgery, but not the anesthesia intervention. So he had created or developed a specific questionnaire with symptoms and distress that could appear after surgery and was related to anesthesia. I mailed him and asked if I could use his questionnaire in a Swedish population. Yes, he said, you can do that. So we tested it in day surgery patients. At that time, it was not Stone Age, but at that time we used paper and pencil. And I and my research group, we discussed, is this what we are going to do now? Use paper and pencil, and in our private lives we use the web. So we started to develop a web-based questionnaire instead. And in this development process, we change the answering scale, and we also change all the items to be negatively, because in the questionnaire, if you have a questionnaire, you can change from positive to negative. It's relatively easy for those who answering. But if you have one question at a time in your iPhone, because it was an app, or you can have another smartphone, then it's difficult if it's changed from being positive to negative. This is an example. Sleep well, we change to sleeping difficulties, because before it could be, do you have any pain the whole time or not at all? And then it comes, have you sleep well? And that was very frustrating to answer if this going, is it positive or negative? And we also did this study with the equivalence between paper and the app, because we wanted to see if you answer this, have the same degree of this distress if you answer on paper or on app, because we wanted to compare our results with those who assessed with paper, and we were also going to assess with paper in our control group and with app, and it was equivalent. We also reduced these items, because and in this reducing process we included patient, we included surgeons, anesthesiologists and nurses. So we ended up with 24 items. And this is very important message, that such interventions, just like drugs or other interventions that we are using in healthcare, have to be validated and have to be evidence-based. So this is nothing that you can just download from the App Store. It has to be validated and evidence-based. So this is the evidence-based phase. We called it RAP, Recovery Assessment by Phone Points. And in this RAP, we have this quality of recovery, or the Swedish web version of quality of recovery. It's patient reported and it's installed in the patient's own smartphone. This is the items or the symptoms or distress that are included. And as you can see, they assess the 24 hours if they have experienced this or not. It could be sore throat because you have this endotracheal tube, or it could be headache, dizziness, diarrhea, feeling constipated due to we use a lot of morphine, or etc., etc. But we also included one more question, and that was, do you want to be contacted by a nurse? You remember that I was talking about that they felt lonely and didn't know where to turn to, and if the recovery process was as it should be. So they asked, the last question was, do you want to be contacted by a nurse? And they answered by yes or no. And if they answered yes, a message went to the day care surgery unit, and a nurse called them up within 24 hours. So it should not be any emergency situation. And we inform patients about that. I will also say that the dot in the middle of this scale started in the middle. They couldn't go forward if they haven't moved the dot to answer it. And they also got a short message to every day, short so that they answer the questionnaire or the app questionnaire. We did this multi-center randomized single-blind, double, two-group parallel randomized control trial. In this analysis, we have 997 day surgery patients, and the data collection was performed during a half year, 2015 and 2016. The intervention group got this, RAP, and the control group, it was ordinary, the usual care. The primary endpoint, it's always important to have a primary endpoint when you are doing randomized control trial. The primary endpoint is used to count for the sample size. So the primary endpoint in this study was cost effectiveness. We have a lot of secondary endpoints. It was the effect of it. It was also the contact with the nurse. If they contact the nurse, and when they contact the nurse, and why they wanted to be contacted with by a nurse, and also the view, the patient view. What did they thought? What did they experience when they used it? This is the results from the patient's view. We interviewed them, and they thought this was great. It was like a VIP track. In Swedish, they said gräddfil, because it was easy to talk to the care, or they didn't feel forgotten. They know that there was someone on the other side. When it comes to the effect, those who didn't have the app or the RAP, they suffered from more symptoms in the postoperative care period. And it was on day 7 and day 14. So more symptoms in those who didn't have any follow-up. And the contacts then. It was distributed almost equally in these 2 weeks. And you can see it's not only in the beginning of their recovery period. It could be up to day 14 that they wanted to have a contact. There were not so many contacts as well, because this is every day. It's half of the population. So it's around 450 patients. And they have one contact. Some of them have up to 3 contacts. But total 84 contacts. And what did they want to be contacted about? It was about wound-related issues, about the plastic, about the stitches, and it was about pain medication, but it could also be about other things that was not related to the surgery, but they wonder if this was related to the surgery or anesthesia. It could be diarrhea, as we have assessed as well. It could be about the information. They wanted to have the information about the surgery because they had amnesia. Even though the doctor talked to the patient before he or she was discharged, all the anesthesia drugs can make them having amnesia. So they didn't remember what they were talking about, what they was informed about. It could also be a question about symptoms like tachycardia and erysipelas, if this was something that was related to the anesthesia or surgery. And you can see on the figure there, the blue line is that the symptoms are more severe in those who haven't that contact the nurse. So every day there was significantly more symptoms and distress in those who wanted to be contacted by a nurse. And how did the nurse handle this contact? 50% of the contact, the nurse could handle her and himself. In 37%, they had to go to the primary care to have more support. But if 13%, the nurse discussed this with a physician or a surgery or an anesthesiologist and could discuss this with the patient. The cost effectiveness, that was our primary aim. We saw that it was less costs if the patient used the wrap. Even though they had equal amount contacts with the healthcare, those who didn't have the wrap used ER, emergency room care, and primary care more. And if you count on how the salary for a nurse, how long it takes to implement the app and inform the patient and the telephone call, it is cheaper to have RAP. And the contacts took in average 6.5 minutes. We also saw in another study that we have missed one symptoms, and that was tiredness and distress. Even though we have involved patients, surgeons, and anesthesiologists in our development process before, they didn't talk about fatigue and tiredness. But when we did interview studies with the patient, we saw that they suffered from a lot of fatigue and tiredness, even though this is day surgery, minor surgery. So we will include that symptom as well in our questions. I have the opportunity to create a company around this. And this is not something that you also can do as a researcher. If you have done any innovation, and if you have got support, you have to have support, because this is not easy. You do not learn to how to create a company when you are a researcher. You have to have support. So I had support from my previous employer, Örebro University, as well as I got external grants to help me to do a company around this. So now we are implementing this RAP in the healthcare. And this is from a journal that in which they talk about how they use and how useful it is to have all this data. I can give an example from this day surgery department. They got new endotracheal tubes, you know, the tube that you put into the patient when they are going to be asleep. And when they used RAP, they discovered that they suffered from more pain in the throat. So they got back to the company that they had bought this endotracheal tube and said, no, we do not want to have this, because the patients have more sore throat now. So this is something to use in quality improvement in the day surgery wards as well. So in conclusion, systematic ESS postoperative follow-up and support can result in a safe, secure patient that do not feel alone or forgotten, a person-centered follow-up, meaning that the patient decide her and himself when to get support from the healthcare. And it can decrease symptoms and discomfort, and it can also be cost effective. However, it needs to be further developed. And as I said, we are going to also assess fatigue, and we are also next step is to translate this to other languages, because if we start with Sweden, everybody do not speak Swedish, and these people are also in need of healthcare and support, and we must also assess how they experience their postoperative recovery. So this is the next step of the development process. Thank you.